thank you firstly to the organisers for inviting me today and a very generous introduction. As you mentioned, I did graduate from Cambridge, but I moved here almost exactly 25 years ago actually as a junior doctor, and I've worked here at the John Rhaghib ever since. Although, as you said, I've done a few other things on the way. And what I'm going to do today is to speak for about 15 minutes about our future health, and then maybe speak about 5 minutes about how I came to lead this project and what inshallah we can learn, or what lessons we can hopefully learn from that journey, and then happy to take questions as well. So before I start, it's great to have so many of you. I've attended only last year. I was abroad for a few years, so I was not around when MRM was set up, but it's great to see that there are so many Muslims now involved in research across all fields. I think when I started in research about 20 years ago, it was much less common. And I think we would have struggled to get even one row of people to a conference like this. So I'm glad it's very good to see so many people today. I was also going to ask you how many of you have heard of our future health. Many of you would have received a letter from me inviting me to take part, but not all of you have, and many of you haven't heard of it at all. So hopefully what I'm going to talk about for the next few minutes will be new to many of you. And for those of you who have already participated, it'll still be helpful to hear a bit about why we're running this study and what we hope to achieve through it, inshallah. Okay, so I know many of you are not in the medical field or in the health field, but some of these statistics that are on the screen will be, if not the details familiar to you, but the broad themes. So we face very large public health challenges, not just in the UK, but really in all over the world, particularly in high middle-income countries, where for the last 100 years already we've had increases in life expectancy. We're only facing the first time over the last 5 years, but we've started to see a reversal in that. And there are a number of reasons for that, some of them I mentioned here. But the real issue is that as the population has begun to age, we are all, I know many of you, well, all of you here are, I think, younger than me, but you're all young, so you wouldn't face this yet. But generally, people get to their 50s and 60s, and particularly up beyond that, they are getting a number of chronic diseases, diabetes, heart disease, cancers, mental health disorders, etc. And this is increasing, and particularly by the age of 70, it says that most people have at least 3 conditions. But it's not just older people, and this is where it's very relevant to everybody, including all of you, whatever age you are in this room. That increasing your health also in working age populations, and even in the age group 18 to 24. You may have seen in the news over the last few months that many people are going directly from university into signing off ill and not being able to start work. There are about 9.3 million people in the UK are economically inactive, and for the first time the largest group of those are people who are unable to work because of ill health. And finally, on the right hand side of this slide, you can see very large health inequalities still exist. So in the UK, one of the richest countries in the world, we still have a 10-year life expectancy gap between places like Blackpool and Oxford, for example, and a 20-year gap between what's called healthy life expectancy, so how many years people live in good health. And now in Blackpool, actually, life expectancy is lower than in many poor countries, including, for example, Bangladesh. The life expectancy for men in Blackpool is lower than the life expectancy for men in Bangladesh, and that shouldn't be happening in a rich country. So there are huge issues we face. And there are some inequalities by ethnic group as well, and I'll maybe come back to that and happy to answer questions on that as well. Although it's a much more mixed picture when you compare outcomes of ethnic groups. Some ethnic groups are actually doing better than whites, some are doing similar, and some are doing worse, but it's very much a mixed picture. Whereas in terms of poverty and deprivation, poor people universally do worse on all healthcare outcomes. So I know most of you here are not in the medical field, but again, you would all have interaction with the healthcare system. And you will know that the way that we deal with disease currently, whether it's in general practice or in hospital care, I myself work as a consultant in acute medicine, which means I see people mainly in A&E when they come with something like a heart attack or a stroke or an infection, that's a severe infection, or a fall, that particularly in the elderly, or a cancer that's already spread. And most of these diseases have developed over years, if not decades. We catch them right at the end. When it's too late to cure the disease, certainly, even to provide good treatment. It's often people have a very poor prognosis, particularly if they've got a severe heart attack or stroke or cancer that's already spread. So this is not good for patients, it's not good for the health system either, and it's not good economically either. So it's bad in all respects. But it's the current model that we have in medicine for hundreds of years has been based on treating people who develop signs and symptoms of their disease. What we want to move towards is a model of healthcare where we can identify people at high risk much earlier, ideally from birth. But
could you click off that middle cross thing?
Yeah, I can't get to it. Sorry.
You can't get to it.
Okay. I was trying to do when I stopped.
If you move the mouse and then look at the screen, can you see the mouse?
Yeah, so the mouse on my screen is not showing that technically. Maybe you'll have to try and ignore that. It's unfortunate it's showing, but it says there, new model of care, precision public health. So there's an important word missing there. So public health historically has been based much more on treating the population as a whole, and that's very important. Clean water, clean air, reducing salt in bread, increasing taxes on cigarettes, etc. That moves the distribution of risk factors across the whole population. But in addition to that, we now have technologies which allow us to identify people at high risk much earlier, based partly on genetic risk factors, but also the whole spectrum of risk factors that people have for developing disease. So we can identify disease much earlier and diagnose people much earlier, and we can intervene earlier and thereby prevent disease. So this is the aim, not just for a UK healthcare system, but any healthcare system across the world. So this is why our Future Health was set up. It was initially announced just over 5 years ago as part of the Industrial Life Sciences Strategy, or Life Science Industrial Strategy in 2019. Set up as a public-private partnership and designed to help people to live longer, healthier lives through better prevention, detection and prevention of disease. It's a very ambitious project and it's a very large project. It's the largest ever health research program, as you've heard from the title. To enable that, it really requires a collaboration across every part of the health and life sciences system in the UK, including, of course, the NHS as a key partner, but also industry, medical charities, and the government. So we are funded, our main funding comes through the UK Research and Innovation, and about half of our funding comes from industry, and about 10% from charities. So we have 4 key aims of the programme, and our Future Health is really being established to help establish the evidence base for this new approach to healthcare and to precision public health. So the first bit was it's a very ambitious programme. So we're trying to set up a resource of 5 million people. The study that I worked on my first research project was something called UK Biobank, which many of you have heard of and many of you would have used in your research if you work in life sciences. And that was set up 20 years ago almost to the day, and it recruited 500,000 people. And at that time, that was very large and very impressive to do that. But what we're trying to do with our Future Health is to get a resource of 5 million people, and the reason for such a large number, particularly for prevention, we want to identify people at risk. The number of people at risk, particularly for most cancers, most cancers are not that common. So you need a very large number of people in order to, so for example, pancreatic cancer, although it's a very deadly cancer, and if you get it, unfortunately, it's a very poor prognosis, it's not that common. And with a resource of 500,000 people, it's simply not possible to understand both the risk factors or how to prevent a disease like pancreatic cancer. Whereas with 5 million people, we would be able to do that. The second thing is that it's not just for discovery research or etiological research, but also translational research, which means that we can take the discoveries from our Future Health and implement them in clinical practice, whether in primary care, secondary care, or in the community, and to understand whether interventions actually lead to better outcomes. Second key thing, and for those of you who are familiar with the programme and hopefully decided to take part, you have the opportunity to find out about your own risk of disease. That's very important because we want to see whether giving people back the risk of disease leads to better outcomes and is cost effective. That's based on both genetic and non-genetic information. And also our current screening programs, and again, you're mostly too young to have had interaction with them, but when you get to 50, for example, you're invited to take part in breast cancer screening, colorectal cancer screening, the young women have cervical screening programs as well. But they're all based on age, not on risk. And although age is the main risk factor, there are many other risk factors. And it's through looking at the whole spectrum of risk factors, including genetic risk factors, that we can identify the right people to screen at the right time. Thirdly, we want to go back to participants and run clinical studies based on their genetic data, on their what's called their genotype, their phenotypes and other characteristics, as well as to take part in clinical trials. And finally, a resource of this size, so about 10% of the UK adult population, means that for the first time we can have really unique insights into the health of the whole population and to understand whether particular population-wide interventions or policies, what impact they have at the individual level. So for those who have not taken part, RFeedHealth is predominantly a digital cohort, so you join online, you fill in you consent online after reading the information sheet, you fill in a questionnaire online, and you do attend a clinic to give a blood sample that's required for our genetic analyses and other biomarkers. What's unique about the UK is that we can combine the data we collect from our participants with the NHS data. And the UK has the largest single health system in the world. The NHS has many problems, which you're all familiar with if you've been following the news at all for the last few years, but it also has a huge benefit that that single system, from a research perspective, is very helpful. There's also, of course, a key differentiator from many healthcare systems that it's free at point of contact without need for an insurance system, and that's very important for equity of access reasons. But there are problems, particularly with waiting lists and waits in general practice, A&E, etc. But from a research perspective, it allows us to link to health records, so hospital records, primary care, GP records, etc. And that is really very helpful, both for understanding exposures in the past, but also looking forward to when people develop different diseases. We will also be able to add additional data. So at baseline, we are collecting relatively small amounts of data, but going forward, we collect data from wearables, from smartphones, from watches, etc. We can link to other databases. So most of what impacts people's health is not in the healthcare system. So in terms of outcomes, the biggest determinants of health are nothing to do with the NHS or doctors or other healthcare professionals. It's what we call social or wider determinants of health, so poverty, education, employment, the environment and the housing that you live in, etc. So being able to link to some of these other databases, whether it's the census or educational databases, employment databases, will help us to understand people's health much better, and particularly to understand how to reduce inequalities. There are also additional biomarkers we can measure in people, so for example proteomics, which is looking at proteins in people's blood, and whole genome sequencing to look beyond just the genotype array that we have, so getting a deeper insight into the biology underlying disease. I'm just going to spend a few minutes to talk about why RFeedHealth is also different to previous studies, particularly UK-based studies. So most studies you'd expect in the UK have been in white ethnic group populations. The UK Biobank example is 94% white. Most studies, with the exception of 2 or 3, are predominantly or overwhelmingly from the majority of white population. But what we wanted to do with RFeedHealth for the first time was to have a study and a resource which included people from all ethnic backgrounds, but not just ethnic diversity, but also by age and by deprivation, and also by geography, so every part of the UK should be represented. So what we've done, and we've been somewhat successful, but there's still a long way to go, is to address some of these inequalities that we see. So for example, if you look at the global database of genetic data, the vast majority of the world's population is of course not European or European origin. That's only about 20% of the world's population. But if you look at the genetic data that we have, it's like 80%. So there's this huge imbalance between genetic data that we have versus the population. There's very little data, for example, from Arab populations, or there used to be very little data, there's a bit more now. Very little from Sub-Saharan Africa, Southeast Asia, South Asia, etc. So most of the world is underrepresented. The UK now has become so multi-ethnic and so diverse ethnically that we have the opportunity to collect data from all these populations within the UK itself. So we have done more to try to encourage people from these underrepresented backgrounds to take part. So we provide clinics in areas all over the country to make it as easy as possible for people to attend their appointments. We give them reimbursement vouchers. And this has enabled us to recruit many more people from deprived backgrounds, ethnic minorities and younger people than any other program in history. This is a couple of things that we did. So in Manchester, we had a clinic, for example, at the British Muslim Heritage Centre, one in the Curry Mile. We worked with the local imams and radio stations to publicise the study. We're doing something similar at East London Mosque soon, inshallah. And this was at the Halal Food Festival in East London recently. So these are the ways that we can make sure. The two groups which I least like to take part, as you see, are from the Pakistani and Bangladeshi communities. And that's mainly because they're younger, more deprived. But it's also because there is a an element of trust deficit amongst these populations, and so we're doing more to try to overcome those barriers so that they can take part. Because you may have heard of the inverse care law, which means that people who most need care are least likely to access it. There's a similar thing in research. Those who can benefit the most from research are least likely to join programs like this. We have open med clinics across the country, in pharmacies, in shopping centres, in supermarket car parks. One in Oxford, I think, is in Cornmarket Street in the Boots there. You are from all over the country, so wherever you live, there's a clinic somewhere near you. But yeah, for those who are local, there's one in Cornmarket Street. So this just shows how many people have joined the programme. This really is unprecedented. There's nothing like this has happened before anywhere in the world. So over 2 million people have joined the programme. Over 1.5 million have completed the questionnaire, and 1.2 million have given blood samples, and that, as I said, is really very unusual. Let's hope this works. So this is showing the location of participants across the UK. So because you can consent online, you don't necessarily have to give a blood sample. There's two different ways of measuring participants. So one is those who have consented, and the other is those who have consented as well as given a blood sample and completed the questionnaire. And you can see for the first time, for any study in the UK, we've got coverage across the whole of the UK, including Scotland, Wales, Northern Ireland, all rural areas, every single county of the UK. So that's very important because, again, to address inequalities across the UK population, you have to have data from all populations. This is just, I don't know if you have any colleagues here from the US, but there's two studies in the US which have also recruited 1 million, or trying to recruit 1 million people. So the Million Veterans Programme and the All of Us Programme, which have very similar aims to our future. But what we've been able to do in the UK is to recruit both much faster and at much lower cost than both of those programmes. So this is one of the few examples actually where we're really far ahead of the US and anywhere in the world actually in terms of this type of research. So I won't go through this in detail, but this is showing, I'm happy for these slides to be shared afterwards if people are interested in the details, but this just shows that we've got much better numbers of people from underrepresented groups, younger populations, more deprived populations, and ethnic minorities, and men. So men are less likely to take part in health research in general, and we've done a bit better than some previous studies. So as I said, by ethnicity, this is in terms of my own previous research, it very much focused on differences by ethnic group, initially in cancer and then during the pandemic with COVID as well. And so it is important to have good representation of different ethnic groups. As I said, interestingly, we've had higher representation from some groups than whites. For example, the Chinese and British Indian are either higher or similar, whereas Pakistanis, Bangladeshis, Black Africans, and Black Caribbeans have been lower. As it's mainly driven by age, partly by deprivation, and partly by trust. If you are a researcher in this field, then you can access the data now. We already have a lot of data available to researchers. So as you can see, there's already 1.4 million participants with questionnaire data, a lot of genetic data and linked data as well. And by this time next year and the years to come, it will be a huge resource for all researchers in health and medicine. This is just a summary of the kind of opportunities that we have in our future health. Again, I won't go through all of them in the interest of time, but it's really very broad range of uses across every aspect of health and medicine and life sciences research. We have a very ambitious aim. We want to enable everyone to live longer, healthier lives, and I hope that whether you join as a participant or as a researcher, you will be able to help us with that. So before I get to questions, I did want to spend a couple of minutes just to say something briefly about my journey to leading this study. It's not common, in fact, it's the first time ever, I suspect, that a person of my background in terms of both ethnicity, religion, and socioeconomic background is leading a study like this. It's not happened in the UK before, it's very unusual in other countries as well. And the reason I put this verse, although it's revealed in a very different context, this was the Battle of Badr, and Allah was explaining that He's the best of parents, but the general rule is valid across all aspects of our lives. We plan, we make plans, and I never planned to be running this study. In fact, I didn't plan to be in Oxford, funnily enough. This is a lesson maybe for me, but for all of us. When I graduated from Cambridge, I was somewhat overconfident about my job prospects, and I only applied for 2 jobs in Cambridge. You meant to apply for 6, but I was overconfident. I only applied for 2, and one in Cambridge and one in a hospital nearby. And I didn't get either of them, and so I was out of the job and about to graduate. This was in December 1999. I was due to start work in February 2000. We were slightly out of sync with those days. So of course I was slightly worried about that, and I thought this was a very bad thing because I liked Cambridge, I wanted to stay in Cambridge, and I had to plan as well as doing Cambridge. And that year, for the first time, I graduated, I passed my exams, I did well, alhamdulillah. But for the first time that year, Oxford opened up their house jobs. For those of you who are in medicine, you have to do a pre-registration house officer job. The first time ever, they opened up jobs in February 2000, and I applied and I got that job, and that's how I ended up in Oxford. And because I ended up in Oxford, I started working with, or I came across someone called Richard Doll, who's a very famous epidemiologist. So Richard Doll used to be the Regis Professor here at Oxford, discovered the link between smoking and lung cancer. And he was the one who really inspired me to get into this field, initially setting up a study that I ran in the UAE Health Teach study. He had won the King Faisal Prize for Medicine, and he said, we don't have any cohort studies in the Arab world, so we need someone to go and do that. I'm not sure why he asked me, I'm not Arab, but he may have seen that my name, and he knew that I was Muslim, so he may have thought it was a good idea. Anyway, it took me another 5 years, well actually it's another 7 years after he died to do that, to go to the UAE and set up this study. And when I came back, that's when I started working on our future health. But yeah, throughout most of my career, I think we're short of time now, but I have to answer questions during the break or after the end of the program. As to, all I will say for now is I didn't plan any stage of my career really. You know, Allah provided opportunities, whether it was UK Biobank or doing a study in, I did some work in India, for example, with the Inox Cancer Research Network, then in the UAE, and then with our future health. And at no stage, I applied for any of these jobs, so people came to me and said, would you like to work on this project? So alhamdulillah, that's a sign that, from Allah, of course. And I think my last slide was just a reminder that I'm very grateful for the opportunity that I've had. It's a very unusual opportunity. And I did want to make a point, of course, what's written here is extremely important. We should be grateful for those opportunities, and there's only come from Allah. But the final point before I finish is that, throughout my time, both as a student or as a junior doctor or as where I am now, I've never had to compromise on my practice or faith as a Muslim. People often think that people can only get to a senior position if they're willing to compromise or to give up things. I've never had to, worked for nearly 25 years now, and I don't ever even had to delay a prayer, let alone miss a prayer. I've prayed in Downing Street, in Parliament, in all these places. There's no restrictions. People know, before they appoint me to this post, they knew that I was a practicing Muslim. And often we think, maybe it goes back to the previous verse, often we think that the powers that be, whether it's the establishment or the senior leadership, that they will prevent people without kind of backgrounds from getting to these positions. I was president of the ISO in Cambridge, I was a senior member of the ISO here. It's a kind of open book, it's not that this stuff is hidden. But it doesn't, alhamdulillah, has not prevented me, and inshallah it won't prevent you from achieving even more in the future. So I'll end there, inshallah, and happy to take any questions.
Thank you so much, Professor. That was really insightful, and I think that last reflection is something that we can all kind of take away and think about in terms of our own lives and how it applies to not only our research but everything that we do. I think we have time for one question. So, I'll hand you the mic.
Thank you for that. Sorry. Sorry. Is that working? Oh, about that. Thank you for your presentation. So I wanted to ask, because the management for many conditions, especially metabolic conditions like hypertension, for example, it often differs based on largely generalized ethnic background. Is there any future intention for robuster findings which could impact on the management of these conditions to be integrated in, for example, medical education, and not just in medical schools, but also for health professionals and doctors currently in training? What's the scope of change in that regard?
So our future health review will for the first time enable that to happen, because it has enough people from different ethnic backgrounds that we can test whether the management and the treatment that we're giving to patients does differ by ethnic. There's some evidence from Genes and Health, for example, that clopidogrel, which is a common treatment in cardiovascular disease, works differently in part-time compared to whites, but we don't have that data for most diseases and most drugs. So this is really the first study which will be big enough to understand both risk factors, how they differ by ethnic group, and also treatments. And then it will take time, and realistically this will take years to implement into clinical practice. But this is the first step, and that's why it's so important that a study like this is being done. I'm going to ask the chair's permission if someone wants to ask a question behind to say this mic's not far away, if that's okay. I know we're running behind time.
Jazakallah khair. Thank you for your talk, it's very informative. I'm actually a dentist and I'm interested to know because obviously a lot of the disease that we see is largely preventable, and unfortunately there are there is already a lot of evidence out there that certain conditions or certain certain people of certain backgrounds are predisposed to developing, for example, gum disease, and then there's also links between gum disease and Alzheimer's and diabetes, and I think there's a lot of associations, but realistically, what can we do? And practically speaking, is there anything that we can start to implement on a community level? Once we see the links, once we identify it, can we start to do, is there scope within the NHS to actually do more community-based intervention and prevention?
Yeah, thank you. Maybe the next speaker is going to use a different computer, so maybe Melissa wants to set that up while I'm answering the questions. Intervention or prevention, most of it has to be done in the community. So whether it's dental disease or pretty much every other disease, we need to start that work in the community, and that's why we've set up our clinics in the community, shopping centres, pharmacy, etc. We haven't thought about dental diseases yet, but it's a good opportunity for us because many of the common risk factors start in childhood or early adulthood, whether mental health disorders, etc., etc. And then, like I said, most of them are not to the NHS, so we need to work with community groups, with people on the ground, and ideally actually at an individual level. So now smartphones have a lot of problems, but one of the good things they do is to allow individualized interventions to people in their homes. And even with things like dental disorders, most of it, as you say, is preventable. So our future health is not just interested in testing pharmacological interventions, but to test non-pharmacological interventions and interventions that are outside of the healthcare system. And happy to discuss afterwards if you're interested in opportunities for that. I'll hand back to the chair.